All right, we are recording now. This is Dr. Hawley, Brian Hawley. Thank you for attending our webinar. I'm glad I remembered to record this because I did two of them already this week and just got so started going and got halfway through and remembered I didn't record. So I had to uh, restart all over again. So, hey, it's life. It happens, right? So we are recording this. So this here is adding therapeutic stretching to your massage, and I'm your host, Dr. Brian Hawley. That's my ugly mugshot down in the corner. It's not me on the table being stretched, okay? That wasn't me in a past life. So I'm in the bottom right-hand side. So we're going to go ahead and begin, and there is a lot of people. Every time I do these, I have a group of people that have stayed with me for a long time, and I think, God bless you. Thank you. I love talking to you guys. And I'm getting a lot more new ones. There's about 60% new ones on this one that I don't recognize the email. So I'm assuming you're new. So um, and about emails, I got to say, I never really, never really started looking at emails. It's kind of like going down the road and you look at license plates. Some of them are pretty damn funny. Some of these emails you guys got, it took some thought. So kudos to you guys. So I get a kick out of reading some of them. Whoever Pookie is, hello. All right, so we're going to go ahead and begin here, and I got some housekeeping. I also got a little disclaimer I wanted to let you guys know on as well. A lot of you know we recently moved about 4 months ago. We moved out on the West Coast. I'm right near the ocean now. I sold my practice. My wife sold her studio, so we could do more educational stuff. I'm going to start doing some live seminars this year. I want to do some where we can have some in-house stuff, and this is what I want to do. So we live near the ocean, and last night, I'm going to see if I can get this. Bear with me here. Yeah. So about 10:30 last night, looked out the window and there's this eerie ocean fog coming in the neighborhood. So I went out on our back deck and shot a picture. Now these lights right down here, uh, those there are the houses that are on the ocean. So the ocean's right there. And all I could think about was, oh my gosh, this is like the John Carpenter's movie, or I think it was Carpenter, The Fog, or Stephen King, The Fog, whoever did the movie The Fog, with the dead pirates come in from the ocean. That's exactly what this is like. So why I'm telling you this is because I woke up this morning with a scratchy throat. I've been hacking and coughing. So I guess the ocean mist or the air was a little dense because we had our slide, it was in the 60s last night during the night. So we left our screen door, our sliding door off the balcony open. So I guess it got a little moist or something. So I got some salt air stuff going on. So if I start coughing or have to clear my throat, I got like a half a gallon of water beside me. Bear with me, but the show must go on, they say. So Jody was going to talk a little bit, but she is worse. She actually lost her voice this morning, so she sounds like she's almost 50, and she sounds like she's going through puberty. Her voice is kind of screechy, so I thought I got this one. I'll come on in and talk to you guys. So what I wanted to do is for some of the new ones, I want to go over some of the questions, just a basic not questions, but housekeeping. So the questions, normally, I normally don't answer the questions. I just keep rolling because we try to cover a lot in a short period of time. And if we go on to a lot of questions, we can't do that. So at the end, I provide my email address where everybody can answer or ask questions. So I have no problem doing that a week, 2 weeks, a month later. I'm still answering questions on a foot and ankle webinar I did 6 months ago. I don't mind at all. So email me questions. That way I can give a good response. My background, who am I? Hell, I'm still trying to figure that out. But my background is in healthcare. I started in the 80s. Went to med school, podiatry program. I was going to work, be a foot and ankle reconstructive surgeon. Work in ER, got burnt out, went to more of a natural way, went to chiropractic school, opened a small chain of clinics, toured the country teaching. My wife was in massage therapy. She worked side by side. Then she opened up her own studio, had massage therapists, naturopath, acupuncturist. And there was a school in our hometown that we actually kind of went in and taught and lectured to the classes. And we had the classes tour our facilities and we talked to the students. And I also started doing energy work. I got certifications in Reiki, went through a lot of different classes. So that's kind of my background. And as I said, the last 6 months ago, we decided to close it all. The kids grew up, moved out, and had this big house. And we're like, hey, what do we do? So we moved. We got tired of the cold, and we moved a half a block from the ocean. So which is very cool. Notes. After this, I'm going to go ahead and upload this here, but I got to convert it and get it uploaded. And as long as the internet cooperates and everything goes good, I should be able to get it done pretty good timing this afternoon. So worst case, I'll get the notes recordings along with the test out to everybody tonight. So give me a few hours to get this done, just in case things mess up. But by this time tomorrow morning at the latest, I hope to get it out tonight, but tomorrow at the latest, you'll have everything. If you don't, again, shoot me the email. That's my best email, info@drbrianhawley.com. I check that probably 30 times a day because that's how I make my living now, and I have a lot of people that correspond with me. I also am one of the chief advisors to a few manufacturing companies, Custom Craft Works, Oak Works. I do a lot of their advising, Pivotal Health Solutions, and a few other things. So I'm kind of busy on the computer, internet, and consulting end. So that's one of the reasons why we sold the practice. So, all right, now let's go ahead and start. I think I covered everything. And let's go ahead and begin. Stretching. Yeah, we all do it, and sometimes we coincide that with a yawn, which feels extra great. But we do it, and it usually feels really, really good, right? When we stretch. Now, I have found that at my age, sometimes if I stretch, I got to be careful because I can give myself a spasm. But normally, it feels pretty good, right? Now, another thing that does good is we all love a good massage, right? It feels good and relaxes. Now, actually, just side note here, I stumbled across an article that I think it was Massage Therapy or Massage Times, I forgot which one. I posted it on our website, Club LMT, or our Facebook page, Club LMT. This is the link. It was actually, they did some research, found that massage actually stimulates the pleasure receptors. That's why it feels good and it lifts your spirits. So if stretching feels good and massage feels good, why would we not want to combine them, right? Now, I know some of you guys do some stretching on some things, but, I want to introduce you guys to taking it to a whole new level. You see, when Jody went out, she was used to working in my clinics with me prior to massage school. She had about 10 years working with me in the clinics, and she did all the ART, PNF on everyone that came in, and so did some of my other staff. And she was used to stretching, so it was just natural for her when she opened her massage and started advertising to mention that she does additional stretching, some ART, PNF stretching and all that combined with massage. And that really set her apart from a lot of the other ones in the community. And what it really did was started bringing her a different form of clientele. She had a whole separate business of just working with power lifters and bodybuilders. And she would charge a lot extra with those because she started doing muscle separation techniques, and that involved a lot of stretching. So what we wanted to do, my wife, Jody and I, we were talking, we were out at lunch, and she said, well, why don't we do one on stretching? Because that's something that really set her apart, and it really helped. And she blended it with the massage. Now, she actually wrote some blog posts and actually sent them out when she was doing her studio. In the ads, she also said like a special for the month, the remaining part of February, or for the next 30 days, our special stretching protocol will be included with your massage. Then she did a little excerpt on why it's beneficial to stretch combined with massage. That got a lot of call to actions. And then later she actually had it as an upcharge if you wanted the full stretching one with massage or just a general massage. And it did a different tier, a different level. So I think it's very cool that we do that. So now, a lot of you guys that jumped on, you've seen the offer, I'm going to go ahead and do a webinar later this week, a private webinar, and you guys will be getting an email that made that cutoff line. I think it was Sunday, I believe. So whoever made that registered by then is going to be invited to the private webinar. And what we're going to do is we're going to build a landing page on Facebook. We're going to design an ad and show you how to promote this ad to your community. We're going to target market it to what we're going to be doing for stretching. And I'll show you how to do that and give you some tips on designing it. So I think that'll be really cool too. Let's get a webinar, learn how to do it, and then next step, how do we promote it to benefit us and tell our community? So we're going to cover those in a private webinar. So you guys will be getting an email, the ones that did the cutoff, you'll be getting an email on that. So again, what can this do for you? It can create a special service for a higher fee. It can provide the client with the undersell, over-deliver mindset. It also helps you stand out from the others that don't incorporate stretching into their massage packets. Okay, I'm telling you right now, physicians, when you start getting their clients or talking to them, you can say, oh, I also do therapeutic stretching on a lot of the recovery in the cases that I do. That's going to ring a big bell with a lot of the chiros and medical doctors in your area as well. Now, it also helps your clients recover and maintain longer, provide an extra skill set that you can use and offer. It also helps clients restore lost range of motion. Okay, obviously that's going to be one of the key goals, especially as you get older. That's the first thing we lose is our range of motion. Now, the other cool thing is, if you're at a show, a sporting event, or sideline thing, if you're have your chair or a table at the end of a 5K run or 10K run, you're not going to do a full-blown massage, but you can darn sure do some therapeutic stretching, and they're going to love you for this. And plus, it's just plain cool to do, right? So, let's get a little more technical now. Some of the mechanical effects. There's different types of effects, so we're going to talk about mechanical first. Now, the stretching techniques which stretch a muscle, elongate fascia, or mobilize soft tissue adhesions or restrictions, right? That's just a very vanilla definition of stretching, right? Now, this here is always accompanied by some reflex effects. Basically, a mechanical stimulus becomes more effective. As it becomes more effective, as the stretch becomes more effective, right, the reflex stimulus becomes less effective, meaning that the muscle is less likely to overcompensate in spasm or cause fasciculations that aren't wanted when it gets more elongated, when it gets to a more relaxed state and has more limberness. I guess that would be a good word. Now, it's also, you can direct the stretching at the deeper tissues, such as the postural muscles, the deep structural, the support muscles that support the structure of our framework. So you can actually do the stretching on the deep ones as well as the superficial ones as well. So that's some of the cool mechanical effects. Now, what are some of the psychological effects? Basically it's beneficial as the physiological, okay? There's a hands-on effect that helps patients feel as if someone is actually helping them and provides a sense of what I call an advanced touch. Massage goes way out there. I mean, it really crosses the boundaries of the touch. It gets the human basic need for touch. It really does. When you incorporate a stretch in there and start stretching with purpose, that little extra bump. It's the little extra 10% that makes the difference. And that actually helps add on to that feeling. It lowers the psycho-emotional and somatic arousal, and hence tension and anxiety. And being, I'm going to say, stretched, more limber, gaining more range of motion, will actually allow the client to feel more free when they're going about their daily tasks. I don't want to bring it in because there may be yoga masters here, but in my mind, I parallel it like with yoga, with stretching. The same feel-good effects that you have with a yoga can be almost felt with this. Okay, now I do yoga. I do practice that, so I'm kind of familiar a little bit, but I'm by no way a master. Okay. Now, forgot I had that picture in there. I have actually had a couple gymnasts that came in for some adjustments, and they were like this girl here, and oh my, you want to talk about a hard person to adjust to get them to move. Geesh. But massage and stretching should never be painful. We know this, guys. Massage shouldn't be painful. Now, there is some techniques where it will get a little uncomfortable. And being uncomfortable is fine. We want to approach that red line, but we don't want to cross the red line. Now, the direction of forces really ideally should parallel the muscle fibers. My wife and my staff, they always begin and end with like a effleurage or some type of a flushing type mechanism, okay? We call it the sandwich approach. Now, also, make sure the patient is warm and in a comfortable, relaxed position before you start doing the massage. Now, certain body parts may be elevated if necessary. Pillow under the head. If you're going to be stretching the plantar fascia on the feet or doing the gastrocs, you can elevate those with bolsters or rolls, okay? Obviously, if you're going to be stretching, you want to do the lubricant, superficial stroke, and the spread lubricant and warm tissue to be stretched. Basic massage principles on those last two, okay? And when you're doing this, it's okay to talk to the client. There's been some massage therapy forums where people are asking, do we talk to the client? Do we not talk to the client? How often do you talk to the client? And there's goes both ways. I'm all for talking to the client when you're doing something like this, but not going on and being chatty about it. Just say, how's that feel? And you also watch their facial expressions when they're laying supine. That'll give you a good indication as well. And whenever I stretch, I do a two-hand stretch. The one hand, or the locking mechanism that holds the limb or the head that I'm stretching, is on that. My other hand is normally on the muscle being stretched. So I can feel the fasciculation. I can feel the tautness in the muscle or the joint I'm stretching. Okay. That way, if there is no verbal, I can still feel it. And sometimes I get better. Well, I won't say sometimes. Almost all the time, I get a better response out of my hand than I will out of the verbal. So that's just practice, to be honest with you. But that's a good clue to remember. Now, the position of you guys, if you're going to be stretching, this goes good with basic body mechanics like you are with the massage. But some of the ones when we're doing PNF stretching or ART stretching, when they push against us, we have to have a firm base, especially if you're stretching a 250-pound guy, you're stretching his hamstrings, and he pushes against you, you got to make sure you're planted. So, I won't read all of this off to you guys, but make sure that you are firmly planted and stable on the ground when you're going to be doing some of these stretches, because you don't want to hurt yourself. Take care of thy own first. Now, there is some factors that will affect the client's or patient's flexibility. Joint structure. There's some way we're born and put together, our joints just won't go too far in one direction. It could be the way we were born. Coccygia valga, coccygia varus, the angle of the femur heads, angle of the humerus heads, and all. There's different anatomical reasons why some people just don't bend. Now, age and sex. Now, we have found that women are more flexible than the guys. And the age, the older we get, like I said earlier, the range of motion is the first thing you lose. Okay? Now, connective tissue. A lot of people may have. I've had some people that worked at a power plant on an assembly line, and the line goes in one direction. So for 20 years, they are kind of cocked, facing one direction, using primarily one side of their body for lifting the widgets and gadgets. Well, they're going to have a lot more connective tissue, a lot more muscle density on that one side than the other. So you're going to have some variations with the limitation of stretching. Weight training with limited range of motion. The power lifters in particular, they would never come in about a week before their powerlifting meet. They wanted their pelvic and hips tight and locked. Same thing with the bench press. They wanted the shoulders and the elbows tight and locked. They didn't want hardly any range of motion in these joints. Then they put on the lifting suit, the power suit, which even really restricted the motion, but it gave them better power for the liftoffs. After that, they came in and we had to really work with them to get some range of motion going. Otherwise, the muscles would start spasming because the muscles were being overworked just with simple things like walking. The other thing, if you do stretch a person, studies have shown that if you do a big stretch right before a lift, it will actually decrease performance of the lift. It's better to do a light warm-up lift and then stretch afterwards, okay? Muscle bulk, obvious reasons, the big bodybuilders with the 21, 23-inch arms, can't comb the back of their hair. You just limitation of soft tissue that's getting in the way on that. Activity levels, sedentary, obese people, what else? I mean, just a little bit of everything else that they're very inflexible. Okay, so keep that in mind when you're going to be doing on some of these clients. Okay, frequency, duration, and intensity. I like to warm them up obviously beforehand. You don't want to stretch a cold muscle, so you want to do a sufficient thing of warming them up. If you don't have time to warm them up with a general massage, like we talked about, go ahead and throw some heat packs on them. Even that would be better than nothing. A lot of time the doctors would always ask me whenever we would do decompression therapy on a disc, they would say, now after the decompression, do you put them on ice or do you put them on heat? Well, if we just sent them home immediately after, which is only like 2% of the group, we would put them on ice to cool them down. We sent them home. But the other 97 to 98% of the people, we did the passive stretching on, and we put them in a rehab thing. So we heated them up. We did an E-stim, an interferential with a hot pack on them for about 10, 12 minutes, and then we went right into stretching, and it worked great. Now, so with massage, you're going to warm them up first. Okay, do your normal warm-ups, get the muscle warm, the area warm, then start passively stretching. Now, again, at the end, we call it a sandwich approach. We start with some type of a flushing massage, stretch, and at the end, we do a flushing massage just to get all the stuff out that we kind of loosened up. Now, for super restrictive muscles, you can hold up to the point of mild discomfort, but not pain, for up to 30 seconds. Now, there's some type of yoga, some styles of yoga even that can hold the position, and the name of the yoga escapes me at the moment. For up to 3 minutes you can hold these things. So, and what I mean by this is I used to tell the clients that, Mary, I'm going to go ahead and we're going to do some stretching. Now I'm going to let you tell me how it's feeling. I'm going to watch you and I'm going to feel also. I want you to go right up to the red line. Now, what I mean by that is this is when it's getting kind of uncomfortable. When we're between 7 and 8, that's going to be uncomfortable. If I go past 8, we're in the red zone. Then it starts getting painful. I don't want to get there. And when you're at home doing stretches, I don't want you to get there either. So we're going to go between 7 and 8, then we're going to stop, take some breaths, let the muscles know it's okay to be in that range, and then we're going to get some good stretching on this. And what you'll find, Mary, is each day we do this, that red line is going to go farther and farther and farther down. We're going to get more limber. That was what we used to tell them, and it worked for years, and it still works, okay? So keep that in mind. Now, there are some types of stretching. We have a static stretch, ballistic, a proprioceptive, or I'm not going to say that big, or proprioceptive neuromuscular facilitation, PNF. We have dynamic and the active release stretch, or active release technique, which describes the stretch. Okay. Now, I'm not going to go in to the certification process and all these. It's like a $1,500 course minimal. We're just going to touch on the basics of these because I don't believe everyone needs these to actually do a good job with them. If you want to further education, by all means, wide open. Okay. Now, what is a static stretch? It's a slow, constant stretch with the end position held for up to 30 seconds. I advise normally holding at least 10 to 15 seconds. What's the reasoning behind that? If you think of the muscle as like an elastic band, if you go ahead and bring it out to its end range, and then you'll wait a second and you bring it back to neutral, you didn't do anything. It still has the elasticity principle. But if you want to create more like a hysteresis or a ligamentous creep, you hold it out in the extended end range for about 15 seconds to 30 seconds. And have the person take a deep breath and breathe while you're doing it. Then you go back, then here's the key also, is you go back slowly. I've seen way too many therapists and doctors just go back quick. That will create a rebound effect, and a lot of times that's when you can actually pull the muscle, and you can actually get some injuries from that. So hold them out for about 15, 30 seconds. Let them relax while they're in that zone, and then go back really slow. Okay, so that's a little tip on that. The ballistic stretch, basically, it's more of an active muscle up. It uses a bouncy motion, which position is not held. Like if you're sitting Indian style, a lot of you older generations, you know what I'm talking about. You're sitting Indian style on the floor, and you're trying to stretch out the adductors, and you do the butterfly stretch, and you see a lot of people bouncing their legs. That's one thing to do. There's many other things you can do, like ballistic stretch, basically. Again, you got to be careful with that for reasons I just said. The dynamic stretch, basically, it involves the flexibility during sport specific. Similar to ballistic, utilizes the speed but avoids the bouncing. Okay, P&F, again, usually this is one of the ones that we used a lot. Perform with a partner, or hence the client and the therapist. It can involve both passive and active. Okay, some say it may be superior to other stretching because it facilitates muscular inhibition. Okay. Now, let's talk a little bit about this. Static flexibility requires no voluntary muscle activity. Okay, an external force such as gravity or a partner provides the force. Okay, in other words, the stretching of the muscle occurs while the body itself is at rest. Dynamic flexibility, and I have pictures because, whenever I was learning this stuff, I read the definition, and all I came up in my mind as a picture was a big question mark going, duh, what? I'm a picture guy, so I included the picture on the next slide. So dynamic flexibility requires voluntary muscular action, whereas static flexibility provides greater range of motion than dynamic, but very similar to functional movement. Let me show you what I mean here. Here's the static stretching. So you can see we're statically stretching these things. Now I got a really good one that does a compare and contrast. So you're not really moving on this. You're getting into these positions and you're holding it for the 15 to 30 seconds, okay? Now, if you do the dynamic, it's more of a functional type movement. You're actually doing stretching like lunge stretching, like a plyometric type, almost like a burpee. Those things are hard. Like a burpee. Dynamic stretching versus static stretching. Excuse me. So those there are the two main types, okay? Now, I always get asked this, what about range of motion? What are we doing with range? So we have AROM, active range of motion, is when the patient or client will perform the exercise or the movement to move the joint without any assistance to the muscles surrounding or resistance to the muscles surrounding the joint. The passive range, the therapist or an equipment, depends on what you have for a setup, moves the joint through the range of motion with no effort from the patient. Okay. Now, AROM, active assisted range of motion, the patient uses the muscles surrounding the joint to perform the exercise, but requires some help from the therapist, such as a strap or just a helping with the lifting. You may see some of these in the very elderly, or if you're doing rehab, say a patient with knee surgery, they're post-knee surgery, and you're trying to do some scar tissue reduction, you're trying to get more range of motion, you're trying to build up some of the muscles, things like that. You may have to help them a little bit, active assist. Now, active resist is when the patient actively resists the therapist while performing the range of motion. Now, clients on the table, which one of the range of motions do we do first? I'll give you a moment. One of the first things that we always did, we were taught this in medical school, then chiropractic school did the same thing, and then this is what I taught doctors. Even doctors would get a lot of this wrong. They would just go ahead and start having the patient, or they would start grabbing and start twisting and everything else. Whenever the client would come in, I always have the client do the range of motion first. I always had them do an active range of motion. That way I could see what they can do, because 9 times out, well, I can tell you almost 10 times out of 10, the client is not going to go put themselves into pain when they're doing a range of motion. Say, for example, a whiplash client comes in. They've been in the MVA, motor vehicle accident. You want to see what their head can turn and what it can flex and extend. I normally go ahead and tell them, Mary, go ahead and look left to right within your comfort zone and tell me right when it really just starts to get aggravating, and stop and hold it, and I'm going to kind of mark the angle. That would be an active range of motion. Same thing with flexion and extension. Okay. Then what I would do is, Mary, now I kind of got an idea where your limits are. I want you to just relax totally and let me do the range of motion. Okay, now if I do the range of motion, then it becomes passive. And I know that Mary can only turn 20 degrees to the left before it starts hurting on her own. If I do the range of motion and I can go in a little bit further and it doesn't hurt, well, then that tells me she has a lot of muscle splinting going on, okay? But if I do the range of motion and it stops at the same place and it starts to hurt and there's no muscle activity, then chances are Mary has some joint issues coupled with the muscle. Okay, so I always let them do the active range of motion first, whether it be the lumbar, the knee, the elbow, the wrist, every body part I'm going to stretch. I tell them do an active range so I can just see where they're at. Then I do a passive. Now, how do we know when to go from active range of motion to active assist, basic or active resistance? Basically, when do we add a resistance to the stretch? So say we're wanting to stretch, oh gosh, what's a good one? Say we're wanting to stretch someone's hamstrings and we're doing some good passive stretching on those. How do we know when to go from the passive stretching to a good active resisting where they're actually working? It's almost like in rehab, how do you go from passive rehab to active rehab? A good indicator is when the patient client, can go from 0 to a normal or close to normal range of motion without an increase in pain. When the client can go from a 0 to a normal or close to normal range of motion without an increase in pain, that is an indication when you can start resistive stretching, when you can start resistive exercises. A good resistive exercises we did was the TheraBands, TheraTubes. Okay, that's when we move from passive exercise to active exercise, from passive stretching to active resistive stretching, when they could exhibit those. So that's why I wanted to include range of motion on a stretching webinar, because I think range of motion gives us a good baseline, and if we kind of get that idea, then we can kind of play that right into the stretching on when to advance on our stretching. Now, going on that train of thought, another good rule is to know what the end feel, or some call end range of motion, feels like. Okay, chiropractic school, this is all we talked about on a lot of them in our adjusting classes, because you can't get a joint cavitation unless you're at the end range of motion or at the end feel, and you have to become very knowledgeable and acute with your hands to know when that is. Now, James Syriac, British orthopod, developed one of the most commonly used systems for physical exam. He identified 6 different end feels, and these are still talked about in the med schools and chiro schools. So the six fields, the 6 fields of feel. Wow. Okay, bone to bone. Sensation, motion is stopped by 2 bones contacting, like an elbow extension or the elbow or the knee extension. You know, you're going to get locked because the elbow you can't extend. You're bone to bone, right? Now, muscle spasm. When muscles are in spasm, they may abruptly halt motion prior to the normal. Okay, this is likely what will benefit. This is likely that pain will be felt at the end of this range because the muscle in spasm will be stretched. Okay, so you have pain stopping you because of a muscle. Okay, you also have capsular. This is almost like a leathery feel. It's not bouncy. It's not like a hard thing like a bone to bone. It's more like a leathery feel. It's there, but it's like you're walking through mud, not wading through water. Okay, that is basically when a true capsular feel occurs when the joint capsule is a primary limitation to the end range of motion, like a shoulder joint, the labia and the glenoid fossa and everything else. That that can cause that type of a feel. Springy block. End sensation, muscle stopping short of where it should by a rubbery or springy at the end. It occurs most often in joints with a piece of loose cartilage like meniscus, joint mice, and all that stuff in the knee, maybe blocking full motion and causing the limbs to bounce a little bit. Okay, It basically has like a small, minute rebound feeling is what it does when you go through these. Tissue approximation. It's stopped by two masses of soft tissue. Think of a bodybuilder. Okay, an example is elbow flexion of the elbow. Elbow flexors, wrist flex, press on each other to limit range of motion, or even a hamstring curl. Okay, so if my biceps were really big and I wanted to do an elbow flexion, I couldn't get to the full joint range of motion because I have a 23-inch bicep. Okay, empty. This has no mechanical limitation to the end. Will not let you go any farther because of excessive pain. Now, this could be another one from shoulder impingement. Okay, so those are the 6 classifications. And if you have another fellow massage therapist or a spouse or what I call a guinea pig, hey, grab joints and start feeling which ones are bone to bone and springy and everything else. And you can kind of get a good idea of these things. And then when your client's on there, you have them do a passive range of motion, and then you go ahead and take them through the active range of motion, start feeling, and you can feel some of these things. Now, why is this important? Real world, what is this going to do? Let's put it into an application. What happens, for example, in an elbow extension? Now, we should have a bone-to-bone, right? When we're extending the elbow out, we should have a bone-to-bone feel, okay? When the olecranon contacts posterior aspect, blah, 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 all the anatomy, right? When those two bony prominences contact each other, we're going to abruptly stop. Now, if you're performing a passive range of motion and you get a soft tissue stretch feel for the elbow extension, then it would most likely indicate some form of restrictive range of motion that should be treated, because you shouldn't feel a tissue stretch at the end of the elbow. It should be a bone-to-bone feel, not a tissue feel. Also, like the medial rotation of the shoulder, you would expect a tissue stretch, okay? But if you got a bone-to-bone, then it could be something else going on. If it was all of a sudden a click or an abrupt stop and not a little bit of a tissue, then you may have to send out, because you know, a rheumatoid or a rheumatologist or an ortho, because you have some joint pathology. Okay, so learning the end feels and knowing where you should feel what is really important when you're dealing with clients and starting to go through range of motion and start incorporating stretching. Okay, very, very cool stuff. Now, joint mechanoreceptors found in the ligaments, capsules, the labral fat pads, you know, the raphe, the Pacinian, free nerve endings, sensitive to changes in the shape, pressure, and rate of movement and direction. Okay. Now, again, these guys are most active at the end ranges of motion. Again, why end range is important. We also have muscle mechanoreceptors. Okay. Muscle spindles are sensitive to changes in the length of the muscle. Golgi tendons. Okay. Let's talk about the Golgis a little bit, and the GTOs. Let me see. I think that's my next slide. Nope. It's coming up, though. Well, we start talking about GTOs. Some of the stretching proprioception stressors is the stretch reflex. During a rapid stretching movement, the IA, interarticular fibers from the muscle spindle, cause an increased activation of the muscle that was stretched and its synergist. This causes the muscle to shorten. What? We don't want it to shorten. We want it to stretch. This should be avoided. Now, so how do we avoid that? Well, careful static stretching does not evoke the stretch reflex. The GTO, not the car, which was a cool car, by the way, is sensitive to muscle tension. When stimulated, it causes the muscle to relax. Now, that may sound confusing. So let me tell you a story about one of the docs that was in the clinic. He was actually working with the sports athletes prior to coming with us. He's a big sports doc. And went from treating the sports guys to the injury people and wanting to gain more range of motion. And whenever he would do a leg stretch, hamstring stretch, quad stretch, it was like he was trying to pump oil or water out of a water spout. He's just going fast on these things. And it took me years to break this guy to habit, and I really never did. But he was doing a fast movement. And what that's going to cause is the GTOs to not relax, to not activate. They're going to cause the muscle's not going to relax, and it's going to shorten, it's going to contract, so you won't get the good stretch that you need. Okay, the better way to do it, now there is a principle before I move on. He was doing it correctly for the sports. It's called preload stretching and preloading before you do an event. Okay, you can fast stretch and it preloads these guys. So when you spring off the starting line or you do a basketball leap or a pole vault or that, preloading is perfect. When you're in the clinic or on a massage table, you're not going to preload. Okay, so you stretch slow. Now, what do I mean by the GTO is sensitive muscle tension? When it's stimulated, it causes the muscle to relax. Here's what I mean. Basically, what happens here is we have, excuse me, we have the organs in the muscle, the stretch receptors. What happens is we have the muscle here, then we have our tendon coming on in. Remember, tendons connect muscle to bone. So we have the tendon coming on in. We have some of the sensory fibers coming down into the tendon. So if the muscle's being stretched at a fast rate, the GTO is not going to relax. It's going to hold that muscle in a contracted state because, man, oh man, it does not want to rupture that tendon. If we have some microscopic tears in the muscle, not a big deal. That could actually be a good thing. That's how bodybuilders get big. We can actually repair that because we got good vascular supplies to the muscle. Not a big deal. But brother, if we're stretching fast, I don't know if we're going to go beyond the muscle border into the tendon border. So the GTO says, you know what, we better keep this thing, we need to keep this muscle contracted because I don't want this to stretch the tendon. So we're going to keep this muscle locked and we're going to fight it. Now, if we go slow, the GTOs are like, you know what, it's all cool. We're going to go ahead, we're watching you, we can see you, you're not going to tear the tendon. Go ahead, we're just going to chill and relax in the lounge chair and let you go ahead and stretch. If you get too close to the thing, we may activate a little, you know, we may stop activating and let the muscle contract, but right now we'll hold the muscle from contracting and let you get a good stretch because we know you're not going to go ahead and mess with our tendons, okay? So a slow stretch will let the muscle relax more. It'll actually activate the GTOs to have the chill factor and let it relax, okay? If you go too fast, then they're not going to react. They're not going to let the muscle chill, and it's going to be tight, okay? So keep that in mind. That's kind of how those work. Hope you liked my analogies. Now, isometrics here. They're a type of non-movement. You know, I'm not going to get in concentric, eccentric, and all those things. I just want to talk about some of the isometrics because we're going to branch into that with the PNF, stretching. They're a type of non-movement in which the joint angle and muscle length do not change during contraction. Okay, it's like you're pushing against the wall. You're not going anyplace, and neither is the wall. Okay, that's an isometric. They're performed in the early part of rehab in a lot of the rehab programs prior to mobilization. They're also used when resistance or a full range of motion could make injury worse. Okay, so again, a good time is in the beginning. They also increase static strength, work to decrease limb atrophy, and create a muscle pump to decrease the swelling. It causes a flushing. Strength gains are limited to exercise, no function, force, or difficult to motivate the client, and force measured being the body. That's the only negative thing about the isometrics. How are these going to be implied? Let's go ahead and look at these, how we're going to be doing some isometrics. PNF, or proprioceptive neuromuscular facilitation stretching, is a set of stretching techniques commonly used in clinical environments to enhance both active and passive range of motion in order to improve motor performance and aid rehabilitation. There's some various forms of PNF. This can get a little confusing, especially in the definitions, so I got pictures. So bear with me through the definitions. I even had to read these like 5 times, and I've been doing it for 20 years. Now, the PNF, the hold, relax. Okay, the therapist will move the limb until resistance is felt. The client will contract isometrically against resistance, meaning the joint isn't moving, the muscle's just sitting there for about 10 seconds. Then the client relaxes for about 10 seconds, and then the limb is pushed to a new stretch actively by the client if performing alone, or passively by the clinician. Repeat that 3 times. Hold, relax, client moves until resistance is felt, contracts isometrically for 10, then relaxes for 10, relaxing the antagonist while the agonist is contracted. Something like a hamstring and quad. Okay. Again, I read those like 5 times. I'm trying to get the picture, so I did some picture grabbing off the internet. So we're going to talk about it with pictures. Hold, relax. Begin with a passive pre-stretch. Right about here, we're passively pre-stretching the hamstring. Therapist is pushing north. Therapist applies force and client holds the isometric contract. The therapist is pushing, the client holds them right there. Or sometimes you can even reverse it. Tell the client to push against you, and you hold them right there. Do it for about 6 to 10 seconds, and then let them relax, and then you can passively stretch a little bit more past this. You can do this 2 or 3 times, and you'll get a ratcheting effect, and you'll gain more out of it. Okay. Now, if they're pushing against you and you're pushing against them, it's neutral and isometric, and you tell them to relax, don't lean forward abruptly all of a sudden, right? Because you'll cause them to tighten up again. You'll scare them. So make sure you got yourself positioned well. I would never do it in this position. I would always do it, obviously, because this guy can just fall forward way too easily. So we always did it in a scissor stance on the side of the table when we were doing this. Final stretch should be of greater magnitude due to autogenic inhibition. Okay. Contract, relax. Again, same thing. Client doesn't. Basically, the first two are almost the same. You're going to be contracting, relaxing. Then instead of just holding it there, the client will bend their leg down, but you're going to resist them all the way back down to starting. Then you'll go back up slower and go a little bit farther. Then when you get to their end range, the red line, you'll hold it, and then they'll resist it all the way back down again to neutral. Then they'll go back up again. Okay, so that's the difference in that type of stretch. Okay. Now, this here is the agonist-antagonist, and let me see here. Begin with a passive stretch. I thought I had another slide, but we'll go through this here. So we get up to the point, the red line, we're holding it, and we're resisting, like in the beginning, we're resisting, and then we're stretching the hamstrings, but right here, instead of pushing back against the therapist, the client will contract their quads. Okay, the antagonist. Okay, we're stretching the agonist, which would be the hamstrings. They'll contract their antagonist, the quads, and then you'll push forward a little bit more. That's another form of PNF. Okay, I personally like one of my favorite one that we used and got really good results was this one right here, the hold relax PNF. That's one that we did on almost all the clients and covered all the joints basically as well. Now, basic principles. Client must be taught through brief, simple descriptions. Starting, terminal, starting the end positions. Should look at the limb for feedback on direction and positional control when learning these. Okay. Verbal commands is firm but simple. Tell me when you get to that red line. What is the red line? Here it is. Right discomfort, don't cross. That's where pain is. Manual contact will facilitate the motions. Obviously, you're going to be pushing on them. You've got to use good body mechanics. I had one therapist that was out on my floor. She had to have been 5'1", 100 pounds with 2 rocks in her pockets. And there was a guy doing a hamstring stretch, and she told him to push against her, and she was just standing willy-nilly, and he basically knocked her on the floor. You've got to make sure you're planted and ready for them to push against you, okay? And again, you got to tell them too, don't try to be He-Man and throw me through the door. Just provide a decent enough resistance, okay? Again, resistance should facilitate a maximal response, allow smooth coordinated motion. Positional release. This is a little bit different. The osteopathics use a lot of this. They were taught this. I was taught this in school. Basically, it's a facilitating force compression. Okay, contact the painful area. I like to use a broad contact, and I have a picture of this also. While holding the pressure, move the limb or head into a position while monitoring pain. If the pain is decreasing while you're holding the area and going in motion, if it's decreasing, then you're going the correct direction. Once the pain drops to a 2 or 3 out of 10 scale, stop and hold that position with pressure for at least 1 minute. Then slow it back to normal while monitor VAS scale, and then do it a few times. What do I mean by this? Say we have a very painful hamstring. So when the leg is extended out, I couldn't find one with it extended, but just imagine the leg extended, we're going to put pressure on the painful area. Then slowly we're going to flex the leg up while monitoring. If the pain is decreasing while we're going like this and holding pressure, the pressure is constant. We don't change pressure, okay? It's about a medium pressure. If it's decreasing, we're going the right direction. We're doing the right thing. Then when we get up to an area, it could be like at a 45-degree angle, 90, or a 110-degree angle. Whatever angle it is where the pain just drops, you hold that angle while you hold that pressure and let the leg totally relax. Do it for about a good minute. Then slowly lower to the neutral position, palpate, recheck, and you may have to do it 3 or 4 times. That's a positional release therapy. Works good in all muscles, all joints. Okay. Now, the new kid on the block, it's been out for years, but compared to stretching, that's been around since eons. The ART is more of the newer one. It's basically really good with acute injury and repetitive overuse, repetitive stress syndromes, or constant pressure tension. It disrupts normal muscle functioning, which affects the biomechanics of the joint, complex leading to pain and dysfunction. And you can also use it to diagnose in some situations, which you guys will not, but a lot of the physicians use it for diagnosing and treat underlying causes. Deep tissue for breakdowns, scarring adhesions, locate point and trap affected muscle by applying pressure over the lesion. Client slowly, and yes, I have a picture, client slowly and actively moves the body part to elongate the muscle 3 to 5 times treatment. We did a lot of this. Maybe uncomfortable. It doesn't feel good if you're doing it right, but it shouldn't be in the red line, okay? Shouldn't be extremely painful. You don't want to create a sympathetic response, okay? Basically, you have the muscle in a flex. You isolate where the pain is, and then you have the leg flexed, and you anchor that pain. You hold it. Then you have them slowly lower the leg back down while you're holding this. Different than the one that we just previously seen, the pressure one. This is the active release technique. You could do it on shoulders, on quads, any muscle. Okay, you put the muscle in a short, whatever joint or muscle you're working with, if it's a painful or restricted, you put that in a shortened state. Like you start off with this, so the hamstring is in a shortened state. You find the area, palpate, and you press on it and you hold it. Then they elongate the muscle, no matter what it is, bicep, tricep, quad, back extensors, neck extensors. That is a good ART technique to use, and you can feel the muscle moving under your fingers. In my video, I do one of I believe it's the piriformis I'm doing, and you can actually feel the muscle rolling, the nodules rolling under your fingers if you do it right. How do you know when you're done? When those nodules start to decrease and you start to feel it loosening up, and when the pain is decreasing, okay? And again, after this, you want to do a flushing technique, obviously, okay? After the ART, I would normally, and Jody would normally, couple up with a very light static stretch also, just to let the muscle know it's free from the adhesion, it's free from the area, and it's okay to stretch a little bit now, okay? Then next visit, we would do the same thing and reassess. This here is autogenic inhibition. Basically, what this is, tension is built up during isotonic contraction stimulates the GTO reflexive muscle during the stretch. Basically, what happens, if you're going to stretch the hamstring, you're not even going to the end range. You're going to kind of hold it right there, and she's going to contract her quads really hard. Then the lady's going to bring the hamstring up a little bit more, and she's going to contract her quads really hard again, then slowly bring it up again, okay? What we're talking about, this is one I thought I had earlier, the image. Then you also have reciprocal inhibition. Relaxation occurs in the opposing muscle, okay? So if we're stretching the hamstrings, keep in mind the quads are going to be relaxed. This phenomenon is called reciprocal inhibition because the antagonists, quads, are inhibited from contracting. The agonists are the ones that are going to be contracting, kind of holding, okay? So you can use reciprocal inhibition to your advantage by knowing this is how it is supposed to work in ideal situations. If you have one hand monitoring the muscles, you can feel if the quads start contracting involuntary when you're stretching the hams, then you're not getting reciprocal inhibition, then there's other pathology, other things going on. Then you need to address that, maybe have them do were they autogenic inhibition, and you may do some active release. Okay, start working the quads. Oh, this is my cue. I'm going to try to get a little video. It's of me. I normally don't do the videos, but I think we're going to start. So this is one of our first ones, and it was a nice day, and we did it out in our back patio. So bear with, this isn't a professional movie studio here. Now, I hope this comes, I filmed it in high definition, so I hope it comes across good for you guys. Now, in the recording, when I send out, the recordings may be kind of grainy or off, so that's why I gave you the YouTube link. Just go right on the YouTube, and then that way you guys can have the link. I have it unlisted in YouTube, so only you guys that have the link can find it. So I'm going to go ahead and hit that and move some things around and let you guys listen to that. And that is me. And sorry about my big belly. I just got through eating a very, very big pasta lunch, which I shouldn't have done before I go on camera. Again, not a camera pro. I will know next time. So, going to go ahead and start here and let you guys listen to this. Then I'll come back on when it's done. Dr. Hawley here. We're outside in our lovely California home here. So we're losing sunlight, but we wanted to do this outside. So you may hear the buzzing of an airplane or something coming by. I apologize. I don't normally do videos doing a presentation, so this is kind of I don't know if it's true or not, but here's what we're going to do. So I wanted to start off. This is Jody. Wait, Jody. She's a massage therapist. She used to incorporate a lot of stretching in with her massages, and it really, really helped. And as a physician with my clients, I would see more people coming in because of lack of range of motion, lack of being able to stretch. And then a shortened muscle, when you put it under a load or a demand, it automatically starts pulling, starts wreaking havoc, start getting fibro tissue adhesions, scar tissue adhesions, and everything else going on. So I thought it'd be really cool to kind of demonstrate some things that we did in my clinic or studio that helped out on our clients, our mutual clients, and that we've seen firsthand. One of the things right off the bat, and then we're going to try to, I'm going to keep this, if you guys know my presentation style, it's very, very informal, okay? So you're going to see us laughing. We may have some outtakes, bloopers, who knows? One of the things I like to do is some subscapular work right around the shoulder, posterior shoulder girdle here. One of the best ways that I have found is two ways, actually. I'll show you one while Jody's just like this, is we would actually have their arm down beside them, and we have like a little foam wedge, or you can even put a towel. My hands are cold, aren't they? So we'll have a towel put under the anterior portion of the shoulder, and that will actually lift the shoulder up. Then we can get under there and work. Now, if I come on that side to work it, I'm obviously going to be in front of the camera. So we'll go this way, and I'll show you guys kind of what we're talking about. We'll lift up, and even if the towel or the pillow isn't enough, you can put your hand under here. And I normally start down here, because up here you're not going to get a lot of space. I normally start down here where the space is, and you can actually walk Jody's girdle right around here. And I'll kind of come in and go up under just a little bit, and I'll just feel. I'm not going to massage or stretch it. I'm just putting tension, and what I'm feeling for is a Gardner reflex. If she doesn't have the Gardner reflex, it tells me she's relaxed, and I'll start gently pushing across and start working the tissue. Now, a lot of you guys already do this. There's another one that really get into. If you could face me on the side, Joe, I'm going to show what I term is the meat hook. And we'll drop the arm behind her, and that brings that, and then I take my palm, and you can really see the hand just bury up underneath the scapula. And then what we do, I get into what's called a scissor stance, and I lift up. And I'm putting pressure, equal pressure forward and up, so my hands are kind of canceling out the forces of each other. You feel that working? And I see a lot of people really liking this, and the things that I see more of is more right-handed shoulders. Any idea why right-handed nowadays? Computer work, working with the mouse.
After about 15-20 minutes, if they have the elbow free floating in the air, the levator scapula starts contracting and starts bringing it up a little bit more, and it starts retracting the shoulder in. So I see a lot of this stuff mainly on the right side. Also, we have a lot of factory workers. If they have a position that they're working at a factory or something, and they're predominantly one-sided on an assembly line, you'll find a unilateral thing. But I always get up under theirs and just go right up in, and you can actually lift them off the table with it. That's why I call it the meat hook. So that's it for that stretch for that. Those are the two that we use. So we'll go ahead and pause now. We'll come back with another one. All right. Now we're back. Another one here that I wanted to show you guys that we did. A lot of with the pec work we would do. Jody just stated she would start off with the face, the head, the neck, and she'd work in with releasing some of the pec muscles. If you find adhesions, knots, nodules, things like that, we're not going to get up in the axillary region. But what I wanted to do is show you what I used to do also whenever I'd be working with a lot of the pec muscles and trying to stretch them. First of all, I would want to check very simply. I'm using this hand not only as an anchor, but just to feel the joint under me. The elbow supported, and I'm just rotating the humerus, the arm. I'm wanting to feel the range. I'm looking for joint mice, crepitus, any type of hinge problems, ball and socket problems, anything in the joints. And if it's all clear, then I get a baseline right here of her range of motion. See, she's starting to get tight here. How I can feel it, I'm not feeling it on this one. I'm feeling the pec tie-in right here under my hand starting to tighten up. So then we'll come on around. She starts to get tight. I can feel it loosen there. So that's her range of motion. That is what you call end range of motion, joint play, end play. So what we want to do is take the subject, Jody, right to the end range, and then we want to anchor and try to stretch a little bit more, okay? We're going to talk in the slide portion about ART, PNF, and using the end range of motion as well. So right now what I'll do, so her end is right there. I'm going to come in just in front of the head of the humerus, go in and go on the pec muscle where it ties in. And I'm going to anchor that. Then I'm going to straighten the arm out, and I'm going to bring it down a little bit more. How's it? Can you feel a stretch?
Yes.
Pretty good?
Yes.
Then we'll come on up, and I'm going to get another bite. We're going to go a little bit deeper out. Can you feel that?
Mm-hmm.
And I can feel it under my hand. When I start feeling fasciculations, a little tightness, then that's when I stop. Reason being that you stop when you start feeling that is because the muscle has to relax to actually get into a full stretch position. If it's fasciculating and starting to guard against, you're not going to get the stretch. And you can work the whole pec muscle all the way from the periphery all the way into central that way. Okay. And there's another one you can actually do that we used to do a lot of times is just the rotator cuff muscles, making sure they're stretched out. That's more of a joint range of motion that we would do, not so much a stretch for the rotator. There's a slide in there that has a broomstick handle for the subscapularis that you can do the stretch on to start stretching that after massages. I'll make sure that's included in my slide presentation. So that gives a good one right there. Another one, come on around that way, Amber. Our camera woman, is actually Amber. She's filming this. So we'll come on around. We stretch this. We stretch the pec. And now if we wanted to stretch the cervical extensors and some of the suboccipital muscles up here. Obviously, you guys know you want to cup your hands up under the subocciput. Many of you guys are doing this, and I can feel the base of it right here, about down by your mastoid. And I'll put a little traction, and then I want to check her range of motion. And I'll bring around very simply, and we'll do both sides to get a stretch. And then what I want to do is come on around. Right here's where I want to anchor, but I want to anchor here, but I want to go a little bit below. So I want to anchor and tissue pull up. That's going to give a stretch. This is my landing point right there, but I want to go right below it, tissue pull up. Then I got her. She's right in my hand. She ain't going anyplace. Then I want to take the shoulder, drop the shoulder, and she's already getting a stretch right there, aren't you, Jody?
Yes.
Then I want to slowly rotate and lift the head up, and she's getting a pretty good stretch. Now, if I was trying to gain range of motion with her, at this point, I'd take her to the end, and I'd have her just simply raise her shoulder up, and I keep the head still. So let me demonstrate that. Raise the shoulder up, and I'll bring your shoulder this way. Bring it this way. There you go. Then drop her down. Take it back. Okay, hold it. Then on the third one, I normally have them go pretty hard. Bring it up, hold it. 3, 2, 1, then relax, and you'll get a little bit more stretch at the end range. And you can do that all the way through. It's a contract release technique. So I would start with doing that and then switch over to the pecs and work my way down. If you really have a person, your hands aren't strong enough, or you have a person with a really big head like I got a big noodle on top, you can take your forearm and come underneath and anchor right here, just like this. And on top of my forearm, her suboccipit's going to sit. This hand is just a guide. And what you can do, actually, I got it the wrong way. I got to go this way if I'm going to be in the camera. So we're going to go up, anchor. I'm going to come over. I'm going to lift up. And I'm using my whole body weight to lift up. You feel that?
Feels better.
You like this one better?
Mm-hmm.
Okay. Same thing on this. Now we're going to stretch this side. And when I stand up, it's not straight. It's going to be standing that way. You feel that? And I'm just using standing up. I'm not using any force at all. And you can direct this hand to turn her head more if you want more of a scaling. If you want more of the posterior stretching. This is the guide to help you with the muscles. Very easy to do. Okay? That'll conclude that. All right, now we have the test dummy subject, Jody, laying on her side. We want to do a quick lat stretch, and obviously stretching the lats is always hard, especially the upper lat and the lower lat. The best way that we've seen, that there's a few ways to stretch them, but the best one that we've seen when they're on the table is to just do a sideline. You can have them on their back, come up, wing it on the side. You can have them land on their stomach, drop the arm off the table, then do a stretch like a swimmer's stretch. You can do those. But just to be easier, I like this one better because you have both hands on the subject and on the muscle you're stretching, so you can feel for fasciculations. And I'll show you a couple of variations of that. So basically we're going to take her up and over, okay? If you want to really get a stretch, you can get a bolster or a small pillow and put under the side to create a bowing effect of the thorax, okay? But what you used to do this a lot with the bodybuilders, right? When they would come in, they do the lat pull downs and stuff. So you want to take the arm, and you don't want to leave the hand in this position. You want to actually turn the arm like that, okay? Then you can take your hand, put it right on the top part of the lat, and drop down as you go down. And it's about a third down, then the rest is going to be down, third in, and the rest will be downward pressure. You'll have lotion on your hand, so you come on down. And as the arm goes down, first of all, just check for the range of motion. You're starting to stop right there, aren't you? Starting to get a little tight. That's where I can feel it under here. Her joint's going to go more, but this is starting to pull right there. So we would start here, and as soon as I start to feel it getting tight, I start rocking my hand down. That's what we do. If we have the arm this way and do it, it's uncomfortable, isn't it?
Yes.
So we'll bring it this way, and we'll drop her on down. And you want to keep the arm straight. You don't want to be bending it as much, okay? If you have a severe tight one, then you can hook under it and you can bend it. You take away the long lever fulcrum. You're breaking the kinetic chain, and you're just doing little stretches, and use your body weight and just stretch as you do it. Now, you used to use your forearms a lot. You would take and do the forearms as you did it. Okay, that's a good one for the lats. If you find as you're going over, you find a trigger point, obviously go ahead and have them just kind of hold their arm there and relax. Kind of work the trigger point as you go in. Just be careful of going up in the axillary region with lymph nodes and everything else. And if you guys took my lymph webinar, you know what I'm talking about. All right, that's it for that one. All right, so now we're going to work the piriformis glute region. This is one that I did a lot in my clinic because I worked with disc pathology, and whenever you have a disc pathology, the secondary thing is always a peripheral entrapment syndrome. So we did a lot of PTs, peripheral entrapment syndromes here, or PSs, peripheral entrapment syndrome. And basically, we all know that the spine comes down. We have the triangle bone, the tailbone right here, the sacrum, and we have from the lesser trochanter of the leg, your piriformis and a lot of your glute muscles will tie in and come around and attach to the sacrum here. So if they're tight, we can pinch the sciatic nerve coming around. The other thing you can see in a client whenever they're in their swing phase, if this is their feet and they're walking, if they have a tight piriformis, one of their feet will be bowing out when they're in their swing phase. This piriformis is pulling it out, so we want to stretch the piriformis. One of the easiest ways, and Jody made a good comment as we were preparing for this, she said first, whenever you're doing this, make sure that you warm up the glute muscles, that you warm up the area really good before you go in and start stretching. So one of the best ones that we do on this, if Jody was already warmed up, and obviously you'd have proper draping and everything else, is you find the border of the sacrum, then we'd be walking the muscle, and if you want to find the muscle, just kind of have it passively work, and I can feel it right under my thumb. Can you feel it, Joe? And you can feel it right under your thumb, okay? So what I want to do is I want to start at the base. I want to rotate it in, because when I rotate it in, I'm putting slack, and I'm tightening it up when I bring it in like this. So I want to grab it right by the base, bring it in, and I want to go down a third, midline 2/3 at the same time. And I'm going to hold this, and then I'm going to bring the leg slowly out, and I can feel the muscle rolling under my thumb. Then we want to come back slow, down, in, and bring it out. How's that pressure? And we'll work this all the way out. Now, as you get out by the acetabular notch and the head of the trochanter down here, or the lesser trochanter where it ties in, it's going to get more sensitive and more palpable tenderness. So you want to be careful when you go down there. Work the whole muscle down, then you want to flush it out. Just do some good flushing after you stretch it. And that'll do it in micro stretch. That's how you isolate the muscle to do the micro stretch. Now, if you want to do a really proficient stretch that ties the glute, and some of the ham in, Joe, can you lay on your side? You want the pillow? What we do is we'll hold the leg, same thing, and what I want to do is create slack in the muscle. I bring this up, the muscle slackens, find the tailbone, in and down toward the tailbone, and I want to bring this leg up around, and then all I want to do is anchor this as I squat down. Now I'll come on around, and we'll do another drop, same thing. If you want to get really intense, what you can do is take the foot, extend the foot, hold it, and internal rotate, and do that. Then you really stretch all this. Is that too much, or you feel it stretching? Feels good? Keep it going. So you can get the premise. It's all about angles. That's what judo was based off of, to be honest with you. So we have that. That is a very good one. On your back, please. The next one, if we're working on the leg, and I'll do this leg to save from the camera, is to come on up. I like to cup them. Now, if they have lotion and everything else, you don't get lotion, you can't do it. So you'll probably anchor the knee joint and feel the knee joint and monitor, and you get right above the ankle on this one. And what I like to do is come in just about where it's a little bit past the 90-degree mark, and then I start rotating in. You can start feeling that right there. We need to start stretching you more. So right there, Jody's getting tight with the rotation. And then once I feel her start to get a little tight, that's when I stop. And then I go up as one unit. And you can really, she's closing her eyes, so that means she can really feel it. Then we'll hold it for a minute, and we have them breathe. We monitor their breathing. That's one way to do that, and then come back. Let them kind of rest a second, do the same thing, and go up. The other way is to come on up, turn, then come up. You say when. Okay, now push back against me, and you hold it. 2, 1, relax. Then you can go a little more. Push back against me. 3, 2, 1, relax, and you can go a little more. Each time you do that, you bite off a little bit more and you can get it going a little more. Does that feel all right? Now, we got that. Now, the other one that I like to do is have them cross the legs, and then we'll come over, and I anchor on the hip right here. I'm sorry, on the shoulder, excuse me. And I put my thumb right under the back of the knee for the web. Then I'll just rotate around. I'll finish it off with that. Can you feel that stretch? Now, if they have a hip replacement or acetabular syndrome or some type of other, like AVN disease, avascular necrosis in the femur head, you don't want to do this one because that's how you dislocate a hip. Dislocate a hip is flexion, internal rotation. That's how the hip comes out. So we don't want to do that. But normal clients coming on in, after you do the piriformis, the glute stretch, have them on the back, just anchor and bring up around. It's a good long lever stretch. They really like that, okay? So now once you do the external parts out here, you want to work the internal stuff. One of the best ones that I have found is I bring the leg right above the kneecap, the patella, just put it right above where the patient is comfortable, and relax. Is that relaxed?
Yes. Okay.
You see this is up pretty high. Jody is very tight here. So what we want to do is find the ASIS, anchor, and then just simply bring this leg down. You feel that?
Mm-hmm.
Then you have her relax and push up on me. Go ahead. Then I hold it. 3, 2, 1. Relax. And then down slow. You feel that stretching?
Mm-hmm.
So that, and you'll do that on both sides. That's working the ball and socket, the little internal muscles holding that together. It's going to be stretching some of the fascia adhesions on that. That is really good. The other one, if a person we're working down the kinetic chain, is the hamstrings. So if we're going to work hamstrings, the typical one is to come on up and stretch like that. What I advise, that's okay. I don't mind doing that, but normally the ones that are coming in, they need stretching. They're really, really acute. Instead of stretching the long, full fulcrum, the kinetic chain, break the kinetic chain and just stretch this part. How you do that, so say if Jody could only go up, you say when? See, she's pretty tight already, and I haven't even flexed the foot yet. Okay, so we'll keep the knee, but that's pretty tight right there. So what I would do on Jody is come down a little bit, break the kinetic chain, come up, and hold the knee, the leg, the upper part of the leg in that position, and then just stretch this part. You say when? Now, curl it back under. See if she's going to do that motion. Go ahead. And I would resist it. Relax. Go up a little bit more. Go down. A little bit more. One more time. Do it 3 times. Okay. And you can see she actually got farther doing that than doing the full lever all at once. Now, obviously, you know the old way. If you guys wanted to, you can put it on your shoulder, anchor it, lock the knee, and come up. And then you can also bring the foot up at the same time you're doing it. That really intensifies it. I like doing it the other way. It's easier on the client until they get really going and they're really limber. Then you can just do the regular old-fashioned hamstrings this way. Okay. While she's here, I was going to show you the quad one that we used to do in the clinic because you really want to stretch the quads. The easiest way I've found to stretch the quads for the clients is that you're working on the quads, you do the cross, getting the fascial bundles and the quads worked, warmed up, and doing whatever you normally do. Then if you want to stretch them, the easiest thing is have them hitched toward the end of the table. Come on around here, Em. And normally I'd have a rolly stool, but I would take the leg, I'd support the knee, and then I would just bring the quad up. You feel that? Then I would hold it. And if they're tight, then you have them extend the leg. Go ahead. And you resist it, relax, and you bring it back more. You can also do this at the same time. I'm going to come in front. As you're coming around, you can put a bolster right here, hanging out, and you can bring the leg down as you're going up. You can bring it down and work it that way. That there's working all the muscles all the way down. That's a good, okay? And it's just a good stretch, and you can bring her on up, squat, and use your legs to stretch it up. Okay? She's pretty good in her quads. It's her hands that's tight. So why don't you flip over and I'll show a calf one. And I'm going to need you to probably come on down where your feet are hanging up. A little bit more. Come on. There we go. One of the best ways that I found to get the calves is to probably come on around over here. So if we're going to get the calves, the easiest way to keep your hands free is to have the feet hang off about 6 inches. And what you want to do is just, if I extend my knee, just bend my knee, it's going to automatically stretch her calf without me even touching, okay? So that's all I'm doing. So right now, I have my hands free to do whatever I want. So I'm going to start at the base, and I'm just feeling the play in the muscle. So what I'm feeling on Jody right now is her lateral head is a lot more restrictive, a lot more tighter than her inner head. Okay, so I'm going to really focus on this with more pressure. So what I'll do, I'll have lotion. I don't have it out here, but I'll have lotion. Then we'll start at the bottom, and we'll slowly bend my leg as I'm working up. Okay? Then we'll ratchet it all the way up. Can you feel that? Mm-hmm. And we'll go all the way up. You can even take the palms if you want. And you can go deep pressure, and you can get the soleus and the gastrocs at the same time. Okay? Then when you get up in the popliteal area, because of the nerve, the vascular bundle in the popliteal area, just kind of lighten up and feather off. Okay? And that is a great stretch. Now, the other thing you can do is if you find an adhesion or a restriction, if it's really restricted, come up on it, park on it as she's flexed. Then you tell her go ahead and straighten her toe out, and you resist it. Relax, and you go a little bit more. Straighten. Relax, go a little bit more, and you can really stretch. Again, because you can see just anatomically, you're really stretching the Achilles, you're stretching these. Make sure you warm them up really good before you go on that. I hope that helps on that. Cut.
Like them to have a bolster or not?
When I do what, the calves?
No, on the feet.
To hold it up?
Yeah.
Yeah. Thank you. All right. I often get asked on this because some of my background, I actually went to osteopathic school. I was in the podiatry program. I was going to be a foot and ankle surgeon. So I know a little bit about the foot. And I started adjusting a lot of the feet that came into our clinic. And we almost had a foot practice for a while. There's 26 movable bones in the foot. So you get one or two little misalignments, subluxations on it, you start adjusting them, and it can make a big difference in the person's overall body. So one of the things I get asked on is how do we stretch for plantar fasciitis? That is huge. And I've seen some on Facebook on the online forums that they have the tennis ball, the golf ball, what do we do? It's a mystery, different shoes, arches. Here's what we did that really, really worked, okay? First of all, have the client lay down on their back. And what you want to do is put a bolster under the legs to kind of get the feet up a little bit, okay? So normally with plantar fasciitis, what happens is you have the remnants of the Achilles come out around, the fascia will go up, and it'll attach up on the balls of the feet, okay? So whenever that does, to find out if they have, so the telltale signs is when they first get up, the first 5 to 10 steps is just murder because it's all shortened from being in bed at night. Then when they get up, it stretches out. And it pulls on those bands and they react, okay? So it's really, really painful. Normally the pain is just anterior to the calcaneus right up here, just right up to the head up here. That's where the pain is. So don't dig in on that spot. So first you have to isolate which band it is. So what we want to do is, normally I do it the opposite hand, but we'll do it this way. You want to take, and you just want to extend the toes back, and you can see, just by doing that, see Jody's one band right there is coming up. So we want to open that up, and it feels almost like a guitar string, really tight. And there'll be little bands, 4 to 5 little bands, and the one that's going to be the culprit that's causing the majority of the problems will appear, okay? So what you want to do then is you want to find that band, You want to hold the toes. The band is right here. I can feel it under my thumb. When it comes down right to where the problem area is, you want to be right there. Relax the toes. You want to put slack in the toes. And then you want to anchor with this thumb. You want to anchor that band to the calcaneus. Then slowly start stretching and flexing the toes out. Can you feel that, Joe?
Yes.
Okay, then you want to get another bite. Anchor, flex the toes out. Anchor, flex the toes out. Okay? You want to work that band, or if there's multiple bands, you want to work that through that. The next part 2 phase is you want to get a good grasp, and you want to do a cross friction all the way across those bands. Now I'm not going in, I'm going across. Just enough to grab it and go across. And you'll work those 3 or 4 times up and down, then you'll go back and you'll re-stretch. That alone, after doing that a few times, will start loosening that plantar fascia, will start breaking it up so the person can have better mobility in the morning. It's not as tight. You'll break up the adhesions. Then for the first week, you have to start off on a tennis ball at their desk or sitting in a chair and just rolling the tennis ball. Then the second week, if all's going good, then you go to a golf ball, start rolling. Doesn't do any good to start off on the balls first unless you get in there and break up those adhesions, okay? That's the best way that I've found to work with plantar fasciitis. Later on in my years, I actually started doing what's called Lodi taping, where we take the white masking tape, the athletic tape around, then we would actually tape it and bring up the arch, and we'd put some spray goop on their feet, and they'd wear it for about a week. But early in the years, just that alone solved a lot of cases, okay? Now, that's not preventing the spur. You know, the spur basically is after prolonged chronic of the plantar fascia, pulling on the bone will start forming a spur because of the pulling. You can't cure the spur, but normally the spur isn't what's causing the pain. It's still the inflammation of the fascia, hence plantar fasciitis. So that is that one. I want to show you another one that we used to do in our clinic a lot. I mentioned earlier when Jody was on her stomach when she was prone, that with a tight piriformis glute muscle, the leg will start rotating out, okay, because it's tight and it's pulling around. So one of the things that an old Eider-Off technique was called log rolling. So what you want to do is have the leg in, and you can actually come under, start at the patella region, grab it. Don't grab the patella. You want to go right above the kneecap, anchor, and roll inward. Then you have Jody roll her leg out. Go ahead. And as the leg slides around, you provide a little resistance. Okay? Relax it. Same thing. Roll it out. Do that 2 or 3 times. Then have them relax and reassess the leg, and you'll start seeing it start to go back inward. That's called a log rolling technique. You can actually watch, there's other videos on it on YouTube. Take a look at that because that will actually help you finish things off. Okay? Anything else that we wanted to hit for the stretches that you did that I haven't mentioned? The lumbar. What was one of your better ones that you liked for the lumbar? Is that on the side and holding the back and bringing it? Okay. One of the ones that Jody liked, it wasn't a long lever lumbar stretch. It was more of a micro stretch. We'd come on around, grab the ASIS, we'd hook it. Then we would take here, and we would kind of go, instead of going up, we'd kind of go cross and anchor, and bring that up as we do that. Can you feel that in the back? Okay. You don't want the pisiform of your hand right on the spinous process. That's painful. So instead, you want the meaty flesh part just lateral to the spinous process of the lumbar. Hook. And it's not so much a firm downward pressure. We don't want to create a kidney problem here. We want to go down a third, then traction upward. At the same time, we're rotating and pulling downward. Then you can go on up. And you may feel some cavitations. You may feel some releases because you're really working. This is actually an orthopedic test that you can do. It's called a Farfan maneuver. All right, guys. You've seen some of the video. I hope it came through okay for you guys. I watched it here. First thing,
I got to go on a diet. Okay, I'm not normally quite that big. Camera does add 10 pounds to you, so bear with me on that. My next video, I'll be a lot trimmer. Those are the main ones that we use, and there's variations of those that you can apply. And I apologize, I think we're about 5 minutes over, so I'll wrap this up quickly for you guys here. And let me see here. And I think at the end here, my computer froze up. And we did. You can see the little hourglass here. I guess the video, there we go. I was going to say it froze up on us. So stretching in the bottom line here is we want to spend more time on the needed areas while on the table. You know, when they're in your clinic, when they're in your office, your studio, you want to spend the time on the needed areas, okay? That's what we definitely want to do. Now, when they go home, I and Jody always encourage them to stretch every day. We kind of gave them some basic stretches to do. And I found the best thing is right before they go to bed, because during the middle of the day, most people are so busy. When they get up in the morning, they got to get out and rush. So before they go to bed, take about 15 minutes and do some light stretching. You know, keep in mind, remind them it increases blood flow. You know, they're flooded with nutrient, helps repair and recover fatigued muscles, and also it helps them sleep better. You know, it does release some endorphins, and you feel relaxed and loose. Okay, so the other thing that I wanted to do, you guys are going to be getting an email out for the private webinar on marketing this. Give me a little bit to get this converted and uploaded, and I'll shoot a date and time either tonight or tomorrow out to you guys. I'm also going to do an online course for target marketing for Facebook. I wasn't going to do it for massage therapists. I'm doing it for the chiropractors, but I think I'm going to open it up for the massage therapy people, because I've had a lot of them emailing asking about, you know, target marketing using Facebook. So it's going to be a complete online course. As of now, I got 12 videos that's going to be in this course. It's going to go from soup to nuts. So I'll make sure that I get you guys that as well. Also, the reflexology I'm thinking on doing, I've been getting a lot of requests for reflexology. So I'm really thinking of doing a next webinar on reflexology. The future topics that's been kind of crossing is some energy work, Reiki. If there's enough response on those, I'll put one of those together for you guys. Also one on business and self-care. So I hope that helps you guys. If you got questions, let me see if my next slide is my email, I believe. Yes. Again, that's my email. Shoot me an email. You guys are pretty free flowing with that. A lot of my regulars, we converse regularly. So I'm actually going to be forming an online private group also, where we can go and discuss things, and I'll try to get on and chat, and Jody will get on and chat. And I'm wanting to get a little bit more intimate with in private with some of the go-getters and start doing things. So I hope you like this. Apologize for keeping you guys late. Anyways, you guys take care. Have a great rest of the week, and I will be yelling at you soon, and I'll get all this stuff out to you. You guys take care, and God bless.